And we'll make a start with Raul Murillo, who we're very pleased to have from South America, who's going to talk to us about HPV screening in low-resource settings. He's a medical doctor with a Master in Public Health. He's currently the General Director for the National Cancer Institute of Colombia, and his primary interest is in cancer research. Welcome, Raul.
I'd like to thank the organizers for this kind invitation to present during this interesting session, and I hope the information I will present is relevant for you regarding the process of implementation cervical cancer screening, HPV cervical cancer screening in developing countries. The content of my presentation talks about the key factors for screening success, the disease, the screening test, and the screening program. But actually, I won't say pretty much about the disease because it is very well known among the attendants. I just want to emphasize that cervical cancer incidence has decreased in several developing countries as it has occurred in most of the developed world. Nevertheless, the burden of disease measured by the disability or quality of life is still very high among developing countries as it occurs in South Asia, Sub-Saharan Africa, and Latin America, and the Caribbean, indicating that alternative approaches for cervical cancer control is highly desirable for these regions in the world. That's the reason we're talking today about this topic. The performance of HPV tests has been widely evaluated around the world, and there is abundant information about sensitivity and specificity of HPV tests. Nevertheless, I would like to present some data that could be interesting for discussing about the implementation of HPV screening programs in developing countries. The first case I would like to present is the pilot experience for HPV screening in Mexico. It was a cross-sectional study where every woman received pap smear and HPV testing. It was conducted in 11 states of Mexico, and it recruited about 50,000 women for the whole study. The first point I would like to highlight is the fact that the positivity rate, I don't know which is the pointer. Yeah. The positivity rate for pap smears was 2.2%, and for HPV was 8.6%, as usually observed. And all women having both pap positive results and HPV positive results were only 0.7% from the total population, which is a relatively low percentage within the screening process. In contrast, the positive HPV women were 7.9%. And I have to highlight the fact that all women receiving positive pap and positive HPV underwent colposcopy, and women having only positive HPV but negative pap were rescreened 1 year later. And this is relevant to me because, you know, the follow-up of positive screen women is maybe one of the major problems in the developing countries. You see that only 47.3% of women that were appointed to be rescreened 1 year later actually attended the appointment. And we talk about the percentage of women, for follow-up in the PAP, based on the PAP smear screening, there will be those having positive PAP and negative colposcopy, and they add only 0.9% of the total population. Of course, it talks about the specificity of a PAP smear, but also I want to highlight the difference about follow-up requirements if we're talking about HPV screening versus talking about PAP smear-based screening. These requirements for follow-up are compensated by the fact that the negative HPV women could be follow-up only every 5 years and not every 1 year or every 3 years, as occurs with the cervical with the pap smear screening. The other topic is relevant in these studies is the fact that the performance of colposcopy among HPV positive women was better, having a higher positivity rate. And also it occurs with the detection of CIN2, and actually most of the CIN2 or more lesions were detected based on HPV, and only 6.7% were detected only based on pap smear in a subgroup of the population in the study. The second case I would like to present is the case of Colombia. In Colombia, we did a community trial. It has 2 arms. In which arm it is the primary screening is pap smear, and the other arm, the primary screening is HPV. we included 3 cities in every one of the branches, and the estimated sample is 40,000 women. Until August 2012, we have recruited around 13,000 women, representing more than 30% of the estimated sample. Here again, the points to highlight are the positivity rate for pap smear, which is 5.0%, and the positivity rate for HPV is 12.0%. Those percentages of positivity rates are higher than the Mexico experience, indicated that maybe the population participating in this study has a higher risk for cervical cancer than the one that participated in Mexico. The other point which is relevant is that the women having positive HPV and positive PAP represent 4.7% of the total population. And there are no differences between the percentages, major differences between the percentage of positivities for PAP and positivities for combined HPV and PAP positive, indicating that the numbers of colposcopies in each one of the branches is equivalent, is similar. But the performance of PAP tests and the performance of colposcopy are highly different. You can see here that 40% of the PAP tests have been positive in the HPV branch, and only 5%, as I mentioned previously, have been positive in the PAP test branch. And the colposcopy has the same performance. It has been better as measured by the number of biopsies taken in women undergoing colposcopy, and also the detection rate for CIN2 or more lesions. Despite these good results, again, we have here 6.6% of women having a positive HPV and a negative pap smear, and those women require further follow-up. And this follow-up is, there's a requirement for follow-up. The number of women that requires follow-up in the HPV branch is higher than the number of women required in follow-up in the pap smear branch. Finally, I would like to highlight here that we had a lower rate of attendance for colposcopy in the branch of HPV testing, and it might be related with some educational characteristics in the population that I will mention later in my presentation. The third case I would like to present is a courtesy by the colleagues from PATH. Those are results from the startup project evaluating rapid HPV testing. It has been evaluated in 3 countries, India, Uganda, and Nicaragua, adding up around 20,000 women. It is a cross-sectional study. All women received here pap smear, rapid test through CARE-HPV and VIA. And the CARE-HPV is provided by, is obtained by cervical sampling, obtained by the health staff, or vaginal sampling, which is a self-sampling by the women. There is important to highlight that the technology used here is the CARE-HPV, which is a very versatile technology, and it means that it's very feasible to implement in low-resource settings and primary care, because it doesn't have pretty much requirements for operation and maintenance. And the time to obtain results are around 2 hours, allowing the possibility to implement see and treat programs in one visit for developing settings, which are very important to reduce follow-up restraints in these screening programs. Here are the results that were provided by courtesy of Dr. Jose Geronimo. I built this figure, which it shows very interesting results. The shapes represent the type of screening test, and the colors represent the countries participating in the study. And there are several trends that we can see here. The first one is, you may see that according to the country, we see different trends. Uganda tends to be less specific than other countries, and Delhi tends to be highly specific, but less sensitive than other countries, than other scenarios. And it occurs not only for pap smear and visual inspection, but also for molecular testing with CARE-HPV, which is the cervical samples and the vaginal samples for HPV testing. And Hyderabad showed the more accurate results, more sensitive and more specific. The second point, which is highly relevant, is that, again, as in previous results, HPV testing is more consistent. You see the results grouped in the given area of the figure for either for cervical samples or for vaginal samples. And finally, you see that the global results, which are represented in the black color, the global results for the study show that there were no major differences between VIA and pap smear screening, indicating that they share both maybe some advantages and disadvantages. Finally, some results from the self-collected vaginal specimens for HPV testing in the Mexican experience. I just want to highlight here that they obtain a better sensitivity rate for either the per protocol analysis or intention to treat analysis for cell sampling HPV than for cytology, cervical cytology, which is a very promising result because it represents the chance to reduce the problems with, for access to screening in developing countries and developing settings. Well, the first part of the presentation will mention some lessons learned from the Colombian experience regarding the program. First, I would like to talk about education. We did some studies previous to start the pilot in our country, trying to understand social representations of HPV infection. What we found is obvious, but we are not always aware about that, is that HPV represents different things for women in a huge range, going from the stigma of promiscuity from a sexual transmitted disease, for the problem of understanding why a very common disease is not considered normally within the population. And the important thing is that the impact those kind of representation could have on the performance of screening programs. There are several results here, but I would like to highlight those related to social behavior that could impact negatively the implementation of screening programs. The other topic quite relevant for screening program, HPV screening programs, is quality of the test. We have had problems in the pre-analytical phase, the analytical phase, and the post-analytical phase. It is important to understand that the way we package the samples and the way we label them could impact the performance of the test, and it could be the reason for finding differences between countries, even for molecular tests. One very relevant point is the refrigeration of the samples. We're not using refrigeration in our program, but it needs a very timely framework for transportation. If we don't have this framework for transportation, we can have problems for being not refrigerating the samples. But I frankly believe that if we wouldn't need refrigeration, it wouldn't be possible to implement HPV screening in developing countries, because it is very costly and very difficult to sustain. And this problem with refrigeration could reflect some problems in the analytical phase. As you see here, we had problem with some of the samples. The cutoff point dropped down in 44 kids, representing 20% of the total samples until now. Fortunately, when we retested these women, we proved that there were no differences with the initial diagnosis on HPV. And also, I would like to emphasize the fact that we have some losses in the process, and apparently those losses were intentional. It means that we have some opposition from the health staff that have been accustomed to use pap smear, and there is a problem in the process of implementation HPV cervical cancer screening. Finally, the problem of TRASH is something interesting as well. I mentioned before that there could be some differences between the performance of the screening regarding the way you use the TRASH for a positive screen women. And pap smear has reported reducing the sensitivity of the initial HPV test, but also I think that the way the pap smear works in a different setting could also affect the performance of global screening, not only because the low sensitivity, but also because the organization and the requirement for pap smear triage with a primary HPV screening. For that reason, we're trying to test in a nested TRASH study within the HPV branch. We're trying to test different alternatives for HPV positive triage, for triage of HPV positive women in our study. Well, we could say pretty much things about this process, but I just would like to highlight some of those findings in the different studies. The burden of cervical cancer remains high for most developing countries, and I frankly believe, and I'm confident, that HPV screening certainly represents a chance for improving cervical cancer early detection in developing countries. Nevertheless, I don't want to be pessimistic, but I have to highlight some caveats for the process of implementation, and that's regular HPV, not care HPV, not rapid HPV testing, but regular HPV will not reduce the short-term follow-up requirements in developing countries. It should be taken into account. There are a lot of women that need follow-up, and that's a big effort for developing countries. And the operative characteristic of HPV technologies might influence the screening performance as regards training and organizational requirements. That's maybe something that explains the results, the different results from different countries, even for molecular tests. And that means that even molecular tests could fail if no proper program is around them. And finally, that complementary test, the trust test, should take into account contextual factors and objectives of screening programs in developing countries. Thank you for your attention.